Good evening and welcome everybody. My name is Alec O'Dare. I am the Managing Director for Wound Care People and the Journal of General Practice Nursing. First and foremost, I'd like to thank every one of you for joining us this evening on, it's certainly in Cardiff, it's a beautiful day, so we do appreciate the fact that you are spending your evening with us. I'd like to also thank L&R, who are the sponsors for this evening's session, and this evening's session is part one of 3 sessions that will be taking place between now and October. So we'll be putting the dates up for the second and third sessions later on in the presentation. But for tonight, we're on part 1, which is the part 1 of the leg ulcer series, which is immediate care to prevention of recurrence. And our speaker this evening is none other than the wonderful Dr. Leanne Atkin, who joins me now. How are you, Leanne?
I'm good, thank you. I am loving the heat, even though I am working in it.
Good. Yeah, I'm pretty much the same, to be honest. I just keep nipping outside every time that I get a 5 minutes just to go and stand out and try and top up my tan. So as always, certificates will be available at the end, and do bear with us if we've got any technical issues. You can see that we're working from our homes. Please do ask as many questions as you possibly can. After Leanne's presentation, I'll be coming back to do the live Q&A as always. So the more engagement that we get from you, the more questions we get, the better that is at the end. I think that's pretty much it for me, Leanne. So I'll come back and, as I said, share the dates for the next 2 sessions. But for now, part 1, over to you, Leanne, and I shall see you after the presentation for the Q&A.
Thanks, Alex, and welcome everybody to this evening's session. It's an absolute delight to be with you this evening. My name is Leanne Atkin. I'm a doctor, but by PhD, so a doctor by research. I'm a lecturer at the University of Huddersfield, but my passionate job is that I'm a leg ulcer clinician, if you like. I'm a vascular nurse consultant at Mid York's NHS Trust, and I'm still down and dirty. Today I've been in leg ulcer clinic, an overbooked leg ulcer clinic, the normal routine within the NHS these days. So I'm delighted to be here, and thank you for the Journal of General Practice Nursing, and along with L&R, who's supporting this session, because I think it's really important that we continue to talk about leg ulceration. And as Alec has said, that this is a 3-part, if you like. We're trying to break down it into easy bite-sized chunks, and today's session is going to focus on that immediate and necessary care, but also that importance of prevention of recurrence. I am here live this evening, so please comment away in the chat box. If you've got any questions, please ask them. Don't think it's a stupid question. If you're thinking it, another person will be too. There is no such thing as a stupid question. There is only ignorance. So please join the debates as we go through this. So this evening, hopefully, by the end of it, what we hope that you are able to achieve is that you understand the national agenda of why are we changing the approach to lower limb management, and why is this so important. And hopefully you will understand and feel comfortable and confident in actually applying the best practice recommendations in terms of that immediate and necessary care, that diagnosis and treatment, and what do you do, and why is it so important in terms of that ongoing maintenance and that prevention of recurrence. So I think all of these sessions really start off, and should start off, with talking about the burden of wounds. And I say this even though sometimes this may feel a little bit repetitive. I think it's really important that we understand the scale of the problem that we are facing as healthcare clinicians at this moment in time. Julian Guest published what we class now as a seminal piece of publication in 2015. It was the first true UK-wide data that we've ever had. And the data he looked at was from 2012 and 2015. And he repeated this study to look at the similar data again in 2017 and 18. And what we're trying to look at is really what are the trends that's happening about wound care across the UK. And unfortunately, the new study shows that over 5 years, there has been significant increase in terms of the annual prevalence, how many wounds and patients with wounds are we treating out there. Unfortunately, there has been a deterioration in health outcomes. Healing rates have got worse rather than better. We have even more increased cost to the NHS, both direct cost and actually the use of healthcare resources. And throughout the UK, the leg ulcers continue to be the most common wound prevalence of all types across the whole of the wound spectrum. So the national picture isn't overly good. If anything, it tells us the burden's getting worse. But some of these figures I just think are astonishing. Within the UK, we are spending £3.1 billion on the care of these patients with leg ulceration. Across the UK, it equates to about 1 million patients having a care of a lower limb wound. So that's about 2% of the adult population. That's a lot of people. And the major issue we're having with this data is that the evidence of recurrence is staggering. If a patient has a healed venous leg ulcer, within the next 12 months, we're finding that 69% of those patients reoccur. So 70%, 7 out of 10 patients reoccur 12 months after healing. So you've got to say, how is that? And you have to question, what's the point of healing them if 7 out of 10 of them are just going to recur anyway? And I find that truly frustrating, because we know how to prevent these things if we get the right care at the right time. So the burden of wounds studies, though, have done a few great things, because actually, if you look at the spend and the rise in spend across the last few years, you can see that wound care continues to play a huge burden, and it remains up there in the top spends across the UK. And this is important because this type of data is looked at by NHS England and NHS executives in terms of how much money is being used within wound care, and can we do anything more effectively? And when you ask that question, can we do anything more effectively? The answer has to be yes. Because if you look at the prevalence by the spend of each wound type, the amount of money is most spent on venous leg ulcers. And this really shocks me. It shocks me because we know from evidence-based practice, we know through empirical randomized controlled studies, we know how to heal a venous leg ulcer with compression therapy and venous ablation. We know how to prevent a venous leg ulcer from compression therapy and venous ablation. But still, even though we have high degrees of high-level evidence, we still are spending a significant amount of money of our percentage of resource in these patients. I can't say the same about having great level of evidence for pressure ulcer prevention or how we heal them. But, you know, it really annoys me in a way that we have that evidence of how to manage patients with venous leg ulcers most effectively. And even though we've got that evidence, we are still spending £3.1 billion every single year on the management of these patients. And when you break down this burden, it's not simply a burden on our community or our practice nurses' time. It's a burden across the whole of the spectrum. It's the amount of health resources in terms of our healthcare support workers helping us to support these patients. The number of visits to GPs surgeries for things like infection, the number of attendance to A&E, the number of drug prescriptions. All of this is a burden across the whole of the NHS. Many of you will know that we've been talking about improving the state of play with venous leg ulcers for many years now, and it really all started to come to fruition, if you like, in 2017, when NHS England published the Right Care, Right Time scenario using Betty's story. Betty's story is a fictional character, but a character that you will have heard of and seen of many times in your clinical practice. It's about a patient who has a skin tear on the lower leg that's treated with simple topical dressings, that goes through a community environment multiple occasions before somebody recognises that actually that could be a leg ulcer. And then there is a time delay of having that patient appropriately assessed, including that arterial assessment and that ABPI. And we are just elongating these patients' suffering and time to healing by this suboptimal care. But what the Betty story really did was brought it back to say, do you know what? If you got it right first time, if you thought about that need for compression from day one at the point of injury, you can actually save 10 times the cost. So rather than spending £5,500, you'll only spend around £500 in healing that patient. I've been in the NHS since 1992, believe it or not. I know I don't look old enough, but I have. And across that time, I've seen rounds and rounds and rounds of cost improvement programs. And within cost improvement programs, it often feels that they're wanting to actually reduce my staffing budgets, or to change some of my staff grading, or reduce the amount of beds or amount of slots that we have. All of that seems a bit wrong to me. But actually, this is the type of cost improvement program that I think we can all get involved in. It's cost improvement program that directly reduces cost, but it reduces patient suffering. It gets them to heal quicker. It helps you manage your caseload. It eliminates all of that. So just a little question for you, really. Maybe we need a little bit of different thinking is needed in order to improve healing rates and reduce the burden to the NHS and the sufferers of lower limb ulceration. Maybe we need to sort of reset our mind and think things differently. And that's what the National Wound Care Strategy Programme hopes to do. The National Wound Care Strategy Programme has got 3 clinical arms: surgical site wounds, pressure ulcers, and then the third arm is lower limb wounds. Because the National Wound Care Strategy Programme recognises that there are a number of unwarranted variations across the UK. And this gives us the opportunity to improve healing rates and therefore reduce patient suffering, the spend on inappropriate and ineffective treatments, and the amount of clinician time spent on caring for these patients. I was part of the National Wound Care Strategy lower limb work stream, if you like, who helped to author these clinical recommendations. And I know I'm biased, but I think they're absolutely fantastic. I think they're fantastic because it talks about lower limb wounds. It talks about any wound that exists below the level of the knee. It doesn't need a diagnosis to go down this pathway. You don't need to recognise it's a diabetic foot ulcer. You don't need to recognise yet that it's a venous leg ulcer. It's one guidance for every lower limb wound that is applicable to every clinician out there. And the guidelines really is set up in 3 distinct phases, if you like. There's a phase on immediate and necessary care, there's a phase about the diagnosis and treatment, and there's a phase about the ongoing management. And this is how we've designed these webinars for you to be able to look at this in these 3 distinct fashions. So part 1, we are going to concentrate on that immediate and necessary care. We've called it immediate and necessary care because we want it to be applicable to everybody in every environment, whether that's a patient in A&E, a walk-in centre, a first contact with a GP, a first assessment for a community nurse, anybody within an outpatient's clinic or a foot ulcer clinic. We want people to be doing the same thing. And the immediate and necessary care has been reflected in the new updated lower limb wound pathway. In 2016, myself and Joy Tickle got together and we produced this lower limb pathway. And we did this to try to really dilute the high volumes of evidence base and bring them down into an easy to follow pathway that any clinician can follow, an easy flow chart, and it will give you a good prompt of how to manage your patients clinically. So this has been updated to reflect that step that the National Wound Care Strategy has put in terms of that immediate and necessary care. So What is immediate and necessary care? Well, the first thing is about maintaining patient safety. So the first thing that we ask you to do is actually just assess every patient that you see for those red flags. Those red flags where you are going to need urgent escalation of that patient, urgent intervention, where the focus shouldn't be actually on the wound care, but the focus should be on the bigger picture, if you like. So the red flags has been described as the National Wound Care Strategy Programme as acute infection on the foot or the leg, acute or chronic limb-threatening ischemia, suspected DVT, and skin cancer. So those terminologies, some of them you will understand straight away. Acute infection, I think many of you will be able to recognise. But maybe you're not so skilled or never been trained in actually what do we mean when we talk about acute or chronic limb-threatening ischemia. So I'd just like to break those down, if that's okay, and just talk about them as individuals, just to make sure that you're clear in terms of having the confidence and the capability to recognise these red flags. So the first red flag is this acute infection on the leg or the foot. Remember, this is the whole of the lower limb that we're talking about. So we're trying to bring into every patient who may well have a diabetic foot infection or a venous leg ulcer. So in terms of thinking about this infection, we'd like you to think about if there's a patient's got any signs of systemic infection. It's a great indication that something's going wrong. So the systemic signs of infection is having a temperature, a fever. Be careful, it doesn't mean if you haven't got a temperature, it doesn't mean that you haven't got a systemic infection, but certainly if you have got a temperature, it's a huge indication that there is a systemic infection going on. The next indication is a tachycardia, a raised pulse, but actually the one that comes across the easiest, I think, is that your patients will complain of feeling generally unwell. They'll feel tired, slightly off it, having flu-like symptoms. All of these are signs and symptoms of that systemic infection. We'd also like you to look for signs of local infection. Wounds, when you've got a break in the epithelial surface, you've got a high chance of bacterial invasion, host response, and therefore localized infection. So just to recap, those localized features of infection is where you've got redness, but with a clear demarcated edge. Within cellulitis, you can actually get a pen, and you'll have seen it, and you can draw around the line. Both of these pictures that you can see here, one is an acute cellulitis and the other is an acute diabetic foot infection. And both of those have got clear demarcated lines between the red tissue and the normal tissue. If the redness is more diffuse and it's like, where does it stop? It's going from red to pale to white. It's more likely to be related to venous disease or other forms of inflammation rather than true infection. Often, especially in patients that's got cellulitis of the leg, the skin becomes edematous, and you can see this orange peel type effect where the superficial skin has become edematous, but because of the skin follicles actually being tethered down to the dermis, you get this like orange peel edema effect. That can be an indication of significant edema and therefore an indication of localized infection. If it is infected, it's 9 times out of 10, it feels warm to touch. It's normally extremely painful for a patient. Just be careful though, with your diabetic patients who's got neuropathy, they could have complete insensation, so pain may not be present. But if pain is present, it is a red flag of why is that there? Is that new? Is that a sign of infection? And if there's any evidence of pus, then that's a huge indication of localized infection. So we need you to screen every patient that you see with a lower limb wound for signs of systemic infection and localized infection. What goes hand in hand with that is actually screening your patients for signs of sepsis. Many of us now have annual training in sepsis recognition, because unfortunately, sepsis remains the #1 cause of preventable death still within the UK. So remember your signs and symptoms of sepsis. It's that extreme shivering, feeling cold. It can result in that confusion, slurred speech, patient not making sense. If the family's telling you there's something not wrong, listen to it. They've got a great ability to be able to assess the normal and the abnormal for that individualized patient. If the patient's more sleepy than normal, or more drowsy or difficult to rouse, think about, is there any signs of any sepsis? If you can often find towards a severe sepsis, you get changes in terms of perfusion difficulties. So you often get pale or blotchy or blue tinges around the lips and the tongue area. If there's any rashes anywhere in the body that do not fade when you roll the glass over it, think about that septicemia. And again, just consider those quick, easy tests: respiratory, pulse, temperature. All of these can be indication of that spreading sepsis. So I think recognizing infection, sepsis, local infection, I think many of you as good wound care clinicians will be quite comfortable at. But the second lot of red flags is when we start to talk about acute or chronic limb-threatening ischemia. And this is something that many of you may only have seen a handful of patients in your career. So the first thing to break it down is acute ischemia. Acute ischemia is a patient who you will be able to recognize. They will say to you, yesterday at 3 o'clock in the afternoon, something terrible happened to my leg, I'm not sure. Ever since then, it's gone white, it's gone pale, I've got pins and needles, I can hardly move my foot, I can't weight bear on my leg, and I'm in absolute agony. You will instantly know from your healthcare professional sixth sense that there's something terrible going on. With acute limb ischemia, it's a limb-threatening condition. You need to be phoning 999. That patient needs to be seen in A&E urgently. But acute limb ischemia, prior to COVID, I probably only saw 2 or 3 in my career. COVID and its prothrombotic nature has made acute limb ischemia slightly more prevalent, but it's still very, very rare. But what you will see a lot of is chronic limb-threatening ischemia, like the pictures that you see here. Many of you may remember it used to be called critical limb ischemia. We've just changed the terminology to chronic limb-threatening ischemia, just like we've changed COAD to COPD. We've just changed the terminology, still the same thing. So the signs and symptoms of chronic limb-threatening ischemia is when you've got what we call a dependent ruber, a red sunset foot, like you can see in this bottom image. Some people can confuse this as infection because it's red, but can you see there isn't a clear demarcated line like we talked about for the infection? It's very diffuse. And actually, if you lift that foot up and raised it, you will find that the redness completely disappears from that foot. So if you've got any redness on your feet and you're worried about infection, the simple thing to do is to raise the foot up. If the redness remains, it's more likely to be infection. If the redness disappears, think about what other signs and symptoms that can be. You get dependency redness, dependency ruber, because of vasodilation. In other words, your body knows that there's not enough blood getting down to that foot, so therefore it just expands every single artery, and therefore you just get flushing, just like you do on a warm summer's day. Many of these patients will have severe pain. Some patients with the diabetic may not have pain. The majority of patients with chronic limb-threatening ischemia have that acute pain. And it classically results in areas of tissue loss like you can see on that picture, on the most distal aspect, on the foot. Chronic limb-threatening ischemia ulceration rarely occurs actually on the limb itself, it's mostly on the foot. This is not an acute emergency. This does not require you to dial 999, but what it requires is an urgent referral to the vascular team. Because if revascularization doesn't follow quickly, further tissue loss will extend. So this is about knowing your routes into your hospitals. Patients with acute and chronic limb-threatening ischemia often have a background of intermittent claudication. So pain in the muscle when they're exercising and only when they're exercising. So think about the actual perfusion to that foot, and that's another of your red flags. The next red flags is if you suspect a deep vein thrombosis. And again, these are the signs and symptoms, the things that you should be slightly worried about. It is unilateral limb congestion, one leg swelling. That's when you need to suspect a DVT. Bilateral limb swelling has many other causes. It can be still a DVT, but highly likely not to be. It's often a sudden onset of swelling over the last 12 hours. If a patient said to you, my leg's been swollen for the last 3 weeks, it's probably not a DVT. But it's about thinking about that acute change. Many of these patients will have this purpley red discoloration like you can see on that picture. The calf will be slightly swollen, and if you actually felt that calf, that patient will be screaming out in agony. You can also ask them to simply flex the foot up and down, and that can often induce pain if you've got a deep vein thrombosis. So if you've got signs and symptoms about a DVT, you've got to be thinking about why has that happened. So you've got to be thinking about, are you at risk of a DVT? And we often consider these in terms of a preceding event. Have you had some surgery recently? Did you have your hip done 3 weeks ago? Are you in a plaster of Paris because you've broken your other ankle and therefore your mobility's changed? Have you been on a long haul flight, but the evidence of that is diminishing every year? But it's about thinking, what's the change of your patient's status combined with that clinical assessment, and have you got a suspicion of a DVT? If you have, the referral route of this is often through a GP walk-in centre or an ambulatory care centre where you can arrange same-day venous duplex scanning if needed. And then the final red flag to screen is that for suspected skin cancer. And these are the ones that still catch me out today. All of these that you can see on these clinical images are types of either basal cell or squamous cell carcinomas. So just look at that ulcer, the actual ulcer that's formed. You may think that that yellow tissue looks a bit sluffy. Actually, when you felt it felt different. Think about what's been happening, because that patient in that picture said I'd had a lump, a blemish in that area that's been crusting and bleeding for quite some time. When it heals, it's really tender and quite itchy, but it keeps recurring. They are the red flags to suspect a skin cancer. And all of these patients require timely biopsies to ensure that we're not mistreating lower limb cancers. They're more common than you think. We used to seem to only get 1 or 2 a year. We seem to now get 1 or 2 a month. So just think about where on your timelines, if a wound is not healing, when do you take a punch biopsy? If you've got any patients with overgranulation that's not responding to treatment after 2 or 3 weeks, I would say think about taking a biopsy. It still catches us out today. So they are the red flags, and hopefully by having that quick 10-minute education, you now feel more comfortable and more confident at recognising those in clinical practice. So once you've screened for those, the National Wound Care Strategy Programme breaks the recommendations down very clearly into a foot recommendation and a limb recommendation. And what we're going to talk about from here really is the recommendation of what should happen for leg ulcers. So after you've screened for the red flags, if there's none of those present, the immediate and necessary care should include cleansing and application of emollient, the application of a low adherent dressing, and the application of up to 20 millimeters of mercury mild graduated compression. And we should be considering if a patient has the ability to do self-supported management. Now, just think about this. Nowhere so far have I mentioned the word ABPI, feeling a foot pulse, looking at signals. This is quite actually forward thinking and quite revolutionary care of patients with lower limb wounds. You screen for the red flags. If there is no red flags, you are allowed to apply up to 20 millimeters of mercury there and then. And the reason why that's been said is that the National Wound Care Strategy really believes that this mild compression, this urgent component, actually is really low risk, and you've got a huge benefit from that early compression. It's about getting that patient into some compression earlier on in their pathway of care. And we've certainly seen this happening once we've implemented the lower limb national guidelines. So it's great to see that wound cleansing and skin cleansing is back in the guidance. And I say that because look at the difference that you can make with 5 minutes of clinician's time, a pair of gloves and a monofilament debridement pad. Which one of these wounds would you feel better if it was attached to your leg? Would you feel cleaner? Would you feel more cleansed? Would you feel more soothed? And from a wound point of view, we've got rid of all of that surrounding debris that well could harbour bacteria. We've removed that superficial layer of sloughy tissue, which is a barrier to healing. We've probably actually debrided a lot of the potential biofilm that could be causing chronicity within this wound. So we've got to bring back wound and skin cleansing with appropriate equipment. The next recommendation is that actually we apply a simple low adherent dressing. The guidance does say with sufficient absorbency, and this is really important. We know that lower limb wounds are highly exuding. It's because of the nature of where they are on the distal aspect of the foot, combined with a lot of these wounds have venous hypertension and lymphatic insufficiency. In other words, you get congestion of fluid in the lower leg. And guess what? If you've got a hole in the skin, the fluid will just leak out. It's really important that we use dressings with appropriate absorbency to ensure that we are protecting the surrounding skin. We're preventing that maceration. We're preventing that extension of the wound size. Each of these wounds have been poorly managed from an exudate point of view. And can you imagine how sore that wound feels in terms of if it was on your leg? Please don't think that using super absorbent dressings are expensive. They're very, very cost effective. We need to appropriately manage that exudate. The most expensive thing within the wound care is actually you and your visit. So once we've done that, it's about applying this first line mild graduated compression up to 20 milligrams of mercury. And we need to be doing this as soon as possible, because any delay in this, we're actually going to cause harm. So there's many ways to apply this mild graduated compression. I don't think any of these are perfectly fit for purpose at this moment in time. They all have advantages and disadvantages. For me, I think the best of these options is to apply a British Class 1 standard hosiery. I say that because we know it gives less than 20 milligrams of mercury pressure. You can use 2 compression hosiery liners instead, because that still is guaranteed to give you less than 20 milligrams of mercury pressure. But sometimes the limb may not be suitable. So if you've got large congestion and lots of edema or highly exuding leg ulcers, sometimes that compression hosiery isn't the best solution. And sometimes we need to be using alternatives such as reduced or light compression bandages. But if you are choosing a reduced or light compression bandage, please know which manufacturer you're using and know what level of compression they apply. Many of the reduced compression bandages actually apply around 30 millimeters of mercury pressure, far too much to be applied without any formal vascular assessment. The recommendation is quite clear. It's 20 millimeters of mercury or less. An alternative to that is to use a compression wrap system. But again, you've got to know which type of compression wrap system you're using and how do you ensure it's less than 20 millimeters of mercury pressure. A further option is to use like Tubigrip. The difficulty is with that is that you'll get cylindrical compression rather than the graduated compression. So I don't think any of these are ideal. I think sometimes you need all of these in your armoury. You've got to think about, how do you, within your specific clinical practice, how do you deliver this up to 20 millimetres of mercury pressure? How are you going to do this? What's the best for you as an individual to be able to treat the majority of your patients? And that's a local discussion and decision to be made. But the benefits of this compression is really, really clear. Remember that if you've got venous incompetence and edema, by the nature, you actually reduce the amount of blood that's getting down there because it's all congested. So you reduce the actual tissue perfusion slightly. The more that you have edema, the more that the capillary beds are pushed apart. So therefore you make the distance, the movement between the cells for the nutrients and the oxygenation, you make it more difficult. Compression therapy helps to reduce all of that congestion. And we used to think that compression may be harmful in patients with an ABPI less than 0.5. Can I just say that the evidence of that is continually changing, because many papers have now been written that you can actually use 40 millimetres of mercury pressure as an ABPI as low as 0.5. I'm not advocating that across the masses. That has to be in specialist hands. But it's just a real recommendation, a real reasoning that please don't be so scared of this, because now we're using that level of compression on that ABPI safely. We've got to remember that compression therapy is a potent anti-inflammatory device. It is fantastic at doing what it does. Remember, when you're thinking about veins and arteries, remember it's not a closed system. They don't connect in terms of the blood doesn't go down and then straight back up again. It actually gets exchanged through that capillary bed, as you can see here on that picture. And that capillary bed, you can see with all the green lines, are the lymphatics. So if you've got venous hypertension, high pressures within those veins, you get a back pressure and you start to get congestion within that capillary bed. And it's that congestion that the compression therapy starts to target. You've got to see a leg ulcer as a bit of a weed. You wouldn't go around chopping the dandelion head off your garden. You need to be thinking about actually what's going on cellular. And the way to get these patients to heal is actually that active compression therapy. We need to target the roots, the veins. I want you to think about going really back to school now, and I want you to think about what happens in that capillary bed in the forms of the blood. So I want you to ask yourself a quick question. What are the 3 components of blood? And I think once you start to understand this, you start to sort of understand venous leg ulcers a little bit more. So just to remind you, the 3 components of blood, the major one is platelets or plasma. Well, once you get platelets or plasma being pushed out through that capillary bed, that's when you get edema. The next product of blood is red blood cells. When you get that congestion in that capillary bed, the red blood cells leak out, they slowly start to break down, but they leave behind them the iron content, the hemoglobin, and that's what gives you that hemosiderin staining. And the final component of blood is that white blood cells. And when they push out, that's what causes the chronic inflammation, the cytokine activity, and that's ultimately what causes that venous leg ulcer. So this is where we need to target our treatment. We need to be thinking about the edema, the plasma causing the edema, the red blood cells causing the hemosiderin staining, and the white blood cells causing that inflammation, that irritation, that venous eczema, the start of a venous leg ulcer. But I just want to ask you a question, really. Why do we sometimes forget about prevention? If you are a clinician out there who's based in primary care or a community setting, you are ideally placed to be able to be thinking about that prevention. We need you, we need your help in terms of identifying who is at risk of developing a wound on the lower leg and what preventative measures can you put in place. Because if you think about this cascade, you can see that the worse it gets, the more negatively impacts on patients and the more resources within the NHS we use. So imagine if we could get that patient when they had that soft edema and early signs and symptoms of venous disease. We may prevent that venous staining. We may prevent that venous eczema, and ultimately we may prevent that venous ulcer. For 5 years, I was the proud chair of the Legs Matters campaign, and I really believe in their headline in terms of leg and foot problems are one of the biggest healthcare challenges of our time. I urge you all to have a look at the Legs Matters website. There are some fantastic resources there for you and also your patients. But what happens if you're trying to prevent and actually a leg ulcer comes about? Well, that's where we need to have a focus on this early assessment and referral. We have placed it there within the pathway that it should be completed within 2 weeks, because if you had a condition, you would want timely assessment, timely diagnosis, and timely recommendation of treatments. This is exactly the same as what the National Wound Care Strategy Programme is saying. So what we'd say is watch out for series 2 of our Facebook Live events, because we will be drilling down into what you need to do to effectively manage a patient with a venous leg ulcer. So, but let's just finish this session by talking about the elephant in the room, if you like, in terms of thinking about, once we've done all of this to get this patient to heal, how do we prevent them from recurring? Because the impact of recurrence is massive. Imagine suffering from a venous leg ulcer, it finally heals, and then it recurs again with a number of months. You would be distraught. It's a huge impact in terms of patients' quality of life, the finances, the workforce, and ultimately your morale, because you spent all that time and all that effort helping to manage that patient, and then all of a sudden they come back again. I just want to remind you that 69% of venous leg ulcers occur annually, but there's lots we can do to prevent this. The ongoing management is spelled out within the National Wound Care Strategy that compression hose rate is a key indication in terms of preventing recurrence of ulceration, and that compression should be renewed on a 6-monthly basis. And this again is reflected in the lower limb pathway. It's quite clear that we emphasize the importance of this ongoing maintenance. But what also is really important, and actually what I think the NHS is bad at, is ensuring that we've got true patient engagement. Patient engagement in terms of a patient taking responsibility for their own well-being, their own health, in trying to improve their own long-term outcomes. There is some great advice within the Squeezed In Club. It gives advice about skincare, footwear, exercise, mobility, rest, elevation, nutrition, hydration, self-care, the appropriateness of smoking cessation and weight loss, the things that unfortunately us as NHS clinicians often don't have time to do. There are some great information within the Squeezed In campaign to be able to support your patient to taking that ownership, to individualise their care plan. Squeezed In campaign is a campaign that L&R supported, and they have got Johnny Vegas leading in their campaign. It really helps to empower patients to take that responsibility back, to really think about how they can help to support themselves in terms of returning to that health. It talks about that first aid of prevention, those early signs and symptoms of recurrence, and what a patient can do about it. So I'd just like to share with you a video about the club Squeezed In, and you may recognise the speaker in terms of Johnny Vegas. Thank you.
I think in an older generation, it's more the debilitating factor is the shame. You know what I mean? That if it's not cared for, if it's not done, to not be as mobile. I think the pressure on younger people, if you look now on social media, to correct themselves, to be perfect. So the first time you see something on your leg and you go, oh, what's that? You know what I mean? I'm less than perfect. We're all less than perfect. Be it on the outside or the inside. If it's an issue with you, find out. I don't think there's any part of us that needs to be hidden away, emotionally or physically. I don't think he felt lonely. If he felt isolated, he probably isolated himself a little bit. I just think there was a sense of pride that came with not wanting to be seen in a vulnerable position. It didn't bother us. He'd been this amazing guy, he'd looked out for us all our lives, do you know what I mean? He'd been a constant source of inspiration, and I don't think any parent wants to be seen in that position. Although he would almost joke that it was the closest he'd got to foreplay in 20 years with my mum, creaming his legs. He saw this as, I'm not indestructible. Not because he was stubborn. It was one more thing he didn't need. And again, to go and get it seen to, I think there was an element of, this is one of the things, you just get on with it, and you don't just get on with it. The sooner you talk to someone, the sooner you learn about exercises, about squeezing, about, you know, support stockings, all these things. I do the same now. I'm in denial and I wake up and it's there as a thing, and I turned up today and I was embarrassed to show my legs off. I thought I was all up for it to promote. And there's me, you know, sort of mouthing off about how, telling my dad what to do. I look at my legs and go, who could love that? Or them.
So I think that Johnny brings that home in terms of how venous leg ulceration and lower limb conditions can really impact on a patient's life. So just in summary, what I want you to take away from today is really that prevention is key. Take every opportunity. Do not turn a blind eye to it. Prevent, prevent, prevent. Think about the end-to-end management, that immediate and necessary care that you can do to stop a chronic leg ulcer from forming. Come to the next webinar to hear about the treatment of a venous leg ulcer, but don't ever forget the importance of that recurrence and the ongoing long-term management. Never discharge a patient who's had a venous leg ulcer. They're going to need your lifelong support because care shouldn't stop once the wound is healed. I love this infographic from Eleanor. It's called A Solution for the Whole Patient Journey. And I like this because it sort of reminds us that a patient can move through this journey. But we've got to make sure that we've got that early intervention. We're using those evidence-based management plans to ensure patients heal as quick as possible. We think about that prevention of recurrence, but embedded in the centre of that is how a patient can actually think about their own self-management. So a few takeaway questions today for you to reflect on tonight. Do you follow an evidence-based pathway to inform your lower limb and leg ulcer care? Question your colleagues about the systems and processes. What is your approach to lower limb management within the trust? Are you all singing from the same song sheet? Do you currently apply that 20 millimeters of mercury compression after assessing for those red flags whilst waiting for the vascular assessment? If not, why not? And how do you ensure your patients know what they need to do in terms of reducing their risk of recurrence? How can you ensure that they take away that full, whole, holistic management? What tools are there out there to help you? I hope you've enjoyed this session. I hope there's been some questions, and I'll just hand over back to Alec. Thank you.
Thank you, Leanne. that was very good. I quite like the fact that because this is part one of a three-part series, we haven't covered actually just too much information in here, and actually there's still lots more to learn. So we do hope that you'll all join us for parts 2 and 3 coming up. There have been, I can tell you, lots and lots of questions coming in. And so we'll get straight on to those. I do apologize, I've got a new dog and he's very excitable. Now I'm talking to a computer. He doesn't quite understand what's going on. So he's, if he barks, that's what it is. So I'll get straight on with the questions. The first is, if we know how to heal leg ulcers, what are some of the reasons they reoccur?
I think it's because a lot of the time we may know as clinicians, but do we actually impart that information onto our patients? Do we drill home the fact that this is often going to be a long-term chronic condition that they're going to need to take some responsibility to manage? And actually, I think it's that bit that we get wrong. I think we're very good at being focused on healing them, get them into the strong compression, get them healed as soon as possible. I think we forget sometimes to reinforce the message of the underlying venous hypertension. What's happening in those capillary beds? Why have you got the edema, the hemosiderin staining, the inflammation? Why is compression important on a long-term basis to keep all of that at bay?
Okay, thank you. The next question is, we have all these new dressings, but still have horrendously low healing rates. Do you think we need to go back to basics?
Absolutely. Truthfully, there's only 2 things that heal patients with venous leg ulceration: strong compression of at least 40 milligrams of mercury pressure, and combined with venous ablation. So venous ablation, we'll be talking about it a little bit when we talk about the treatment of leg ulcers. That's basically varicose vein surgery of one form or another. We know that turns a tap down of the internal pressure and to stop those leakage within that capillary bed. But that needs to be done in combination with strong compression. It doesn't really matter what dressing you put on underneath the wound. It's about managing those patients' symptoms in terms of exudate, but it's that strong compression. Yes, go back to basics. Cleaning and cleansing needs to be brought back. That's the best thing you can do for your patients, with good, active, mechanical debridement to disrupt that biofilm.
Okay, thank you. The next question is, why is it 20 mmHg or less for immediate and necessary care? Why is it 20 milligrams or less for immediate and necessary care?
Because it was a figure that we all agreed on. So I can tell you, when we wrote this from the National Wound Care Strategy, we all believed that a degree of compression was needed here and now. There was talks about whether it should be 30. We were concerned that if you're not doing any form of arterial assessment, if you've got a patient with critical limb ischemia that gets the wrong diagnosis and you put 30 on, you could actually be causing significant harm. We had a group of clinicians, vascular surgeons, vascular technologists, vascular nurses, tissue viability nurses, podiatrists. We were all in agreement that actually probably the safest level to go for is that 20. That were hard to get through. You know, many people wanted an ABPI on everybody. So, you know, we had to go to a level that we all felt was safe, and that's where it currently sits. It may change in the future as more evidence comes out, but I think it's really important that we set that barrier. And I think that whatever you're applying, make sure it's at that level or below. Don't go above it just yet. We just don't 100% know if above that is safe without a form vascular assessment. So just keep it below that level as now. It was a bit based on the literature, it was a bit based on consensus, and it were a little bit of finger in the air.
Okay, brilliant. The next one is a question that comes up quite regularly on any of these events that we do, which is how do you overcome a patient's non-compliance?
First off, stop using the word non-compliance. I hate it. Absolutely hate it. It's fantastic that we can blame the patient. It's your fault. You're non-compliant. Well, do you know what? If you put on a compression bandage on my leg in this heat, I'd be non-compliant. 100% I'd be taking it off. Especially if it started to fall down a little bit, or I had a dressing that I exuding everywhere and it became smelly, I'd be taking it off. You'd be labeling me as non-compliant. It's about working with your patients to find out what treatment they want. Because I won't go in a compression bandage for you, but you know what? I'd have a hosiery kit on, one that I can bath and shower, take it off when I like. As soon as my dressing starts to get a bit smelly, I can change it myself. I'll comply with that. So I think it's about ensuring we've got individualised patient care, taking into account what they want. And it's got to be on the background of, let me tell you why compression is so important. Let me talk to you about that leakage and that inflammation inside. And no wound dressing is going to help that. The only thing that's going to help this is this strong compression. Which form of strong compression would you like to wear? And I think it's about reframing that narrative and that conversation. We are fantastic at blaming our patients. I think we need to look inwardly a little bit first before we can 100% say the patient is truly being non-compliant.
I think that's a slightly controversial take, but I wouldn't expect anything less from you, Leanne. There you go.
Completely controversial, completely. But I can tell you, many of the progressive practitioners across the UK thinks it's an unhelpful term.
Brilliant. Okay, so the next question is: if there's no edema, do you still need to apply compression?
100%, yes. You cannot see venous hypertension from the outside. So you remember the 3 components of blood that may be leaking. You may have mild edema, you're not losing that much plasma, but you might have some hemosiderin staining, and then you'll certainly have some internal inflammation. You cannot see venous hypertension from the outside. You need that strong compression to treat those roots, of that weed within that venous ulcer. So full, strong compression is required to heal a patient with a venous leg ulcer. What I would say, though, is you might need a slightly different treatment if you've got substantial edema. So compression hosiery kits are great for no edema. Compression hosiery kits are European in nature, such as the Acti-Lymph range, are fantastic for mild to moderate edema. If you've got significant edema, you might need to put a compression bandage on to actually reform and reshape that leg. We'll be covering all that in part 2.
Nice little link there. There you go. Brilliant. Next question: what would be the timeline for urgent vascular referral with chronic limb-threatening ischemia?
What a brilliant question, whoever asked that. Okay, so the standards across the UK is for an outpatient to be referred, seen, imaged and revascularized within 14 days. So I can tell you it'll take me 7 days to get an image and to get a revascularization procedure. It'll probably take you 1 day to do the referral systems. So actually from point of referral to being seen in vascular, we're trying to work on 48 hours. Okay. It's a chronic limb-threatening ischemia. It's one of the worst things that we do, apart from ruptured aneurysms. I understand that the capacity may not be there, that we need it, but that doesn't mean a patient should be referred. You need to be referring, you need to be chasing, you need to be demanding. Have a look at the sequin. There is one for chronic limb-threatening ischemia that outlines all of that. If you look at the Vascular Society guidelines, it talks about inpatient revascularization and outpatient revascularization. Inpatient 5 days, outpatients 14 days. So it's a tough target, but that's what we need to be aiming for. That's our problem if we haven't got the capacity. What we need you guys to do out in community is refer urgently with that urgent referral, suspected chronic limb-threatening ischemia. That starts our clock. It starts to push a patient through our timeline.
Okay, brilliant. And what we'll do is we take notes of anything that you say if they're not links and things on the slides and stuff already. So things like things that you just mentioned, we'll find links to those and we'll put them up onto the website along with a copy of this presentation tomorrow. We've got 1 or 2 more questions, then I think we're done just from a timing point of view. Lots more have come through, and as I usually say, so this will be the last question, but if you have asked a question this evening and we haven't got to it, then what we tend to do is we take a note of all of the questions, we put them into a PDF, and then we share them with Leanne and with Eleanor and any other people that can respond to those. And then from tomorrow, or what day are we, Wednesday, probably from Friday actually, a copy of a copy of this presentation will be available on our website, along with a PDF of the questions and answers. And of course, if you, I noticed that some people said that they missed a bit of the presentation at the beginning. So if you've done that, then you'll be able to watch this immediately when we finish by just going back to the start via our Facebook page. So the final question, Leanne, is how do we overcome the pain and discomfort the patient encounters whilst trying to work in preventative compression hosiery?
Okay, so you've got to remember really why the pain is there. The pain is probably, we know more and more that actually it's probably a neuropathic related pain rather than anything else from an activation of the nerves. And that's probably there because of the inflammation inside. So you've got overactivation of the nerves because of the inflammation. So therefore, the way to get all of that solved is strong compression as early as possible. I appreciate it's a challenge because you're asking a patient with an already painful leg that you're going to put on something that's going to be tight. Number one, don't use the word tight. Talk about a gentle squeeze. Talk about the internal inflammation. Talk to the patient to say, do you know what? You might find it slightly more uncomfortable for the next 48 hours. Take regular painkillers, depending on what they're already taking. Take regular painkillers. Keep the compression on, and I promise you, within 7 days, the pain will start to get better, and within 14 days, your pain should be practically gone. The pain is there because of the inflammation. You need to be targeting that inflammation. The more that you talk to a patient, the more that you help that patient to understand their pathophysiology, the better your engagement will be with that patient.
Okay, brilliant. Thank you very much. I think that's us done for this evening. We've got 2 more sessions. I'm going to put the dates up on the screen. So the next 2 sessions to follow up on this are the part 2 will be the 30th of August. That's with me and you again, Leanne, and that is progressing towards self-care. And then we're back then sort of towards the winter. This sun will be definitely gone by then on the 11th of October, which is embracing supported self-care. So do please save those dates. That's the 30th of August and the 11th of October, because we'll be back for parts 2 and parts 3. There should be some links on the screen now to there's a call to action slide from L&R, where if you've got any queries or questions, you can actually contact them, and their contact details will be or should be showing up on your screen now. A link to download certificates, as always, will be available in just a moment or so. So please do that. This event that you've taken part in does count towards the CPD. I just want to thank my team and thank L&R, as always, for supporting these really quite they're really needed. I think these events. You can tell that just from the questions and the comments that we get throughout them. So thank you very much to L&R, and thank you very much to my team for working in this wonderful heat. And final thanks go to all of you wonderful people and healthcare professionals at home or wherever you are watching from. I did see 1 or 2 people say they were watching from Greece on holiday, which is quite a nice thing to be doing, isn't it? Although we've probably got better weather than them at the moment, so let's not be too jealous, Leanne. Thank you very much, everybody. Have a good evening, and we shall see you at the end of August for the part 2. Good night.